friends, let's continue our session on obesity. Previously we discussed on introduction, causes, assessment and prevention of obesity. In this session, we will learn intervention of obesity. So, let's continue our session. Intervention. There are most two important intervention to manage obesity. First is optimal nutrition and second one is increased exercise and physical activity. Fitness is nowadays is most concerned is associated with the more desirable clinical outcomes in many instances such as decreasing metabolic disease, cardiovascular disease, Alzheimer disease risk, inflammation and many other diseases. If the patient is able to do exercise, and exercise may be the preferred route to decrease disease symptoms and the future risk compared to the alternative pharmaceuticals that may exacerbate the symptoms. If the BMI is 25 or less, the physiotherapist should provide the health promotion information between the 25 and the 28. They should offer the simple weight control advice such as amount of calories consumed in relation to the physical activities. If the BMI is more than 30, means education about the health risk offer and simple weight control advice such as the amount of calories consumed in relation to the physical levels. If the patient wants to lose weight, the physiotherapist should advise the patient to go to the doctor to devise a strategy for weight loss and which would include the help of other health professions such as the dietitian, nutritionist and the behavior therapy. Patient's education. One of the main roles of the physiotherapist regarding obesity is educating the patients. Many people are falsely led to believe that they can lose weight without putting in effort or changing from the sedentary lifestyle. Physiotherapists have to explain why it is not true, because if the patient doesn't understand why this is incorrect, they will continue to believe it. When a physiotherapist meets an overweight person or the person who can't do the exercise required for the treatment, they should sensitively express their concern about their body weight and check their BMI. It never pays to get the client offside. Next one is tailoring activity goals to individual patients. The physical activity should start at a low level and gradually increases, and find out which type of activity is physically possible for this patient and the barriers that can prevent a successful increase in activity. The compliance to exercise can be enhanced by increasing the lifestyle activities, for example, climbing stairs, gardening, and walking the dog. The developing an appropriate home based exercise program and considering short bouts rather than the long bouts of the activity for patients who can't find the time to exercise. Is self monitoring. The self monitoring is the cornerstone of the behavior treatment of the obesity, and monitoring raises patients' awareness of their exercise habits and helps them identify ways to maximize their energy deficient. The evidence and the recommendation on how to treat obesity in the adults have been subdivided into: first is the dietary intervention, second is the physical activity, third is the behavior intervention, fourth is the pharmacological treatment, and the last one is the bariatric surgery. That is the last option to manage obesity. First is the dietary recommendation. Avoiding the consumption of calorie dense, nutrition poor foods, for example, sweetened beverage, sports drinks, fruit drinks, and juices, and most fast food and the calorie dense snacks. You have to avoid that. The ideal beverage for the children at all meals and during the day is water. Reducing the statutory dietary fat intake for the children older than the 2 years of the age. Increasing the intake of the dietary fiber, fruits and the vegetables. Eating timely, most important, regular meals and particularly the breakfast. Some people believe that skip that breakfast you have to reduce that obese. It is wrong. So you have to take regular breakfast. Avoiding the constant grazing during the day and controlling the calorie intake through the portion control. Low calorie diets are recommended. Low calorie could be carbohydrate or the fat restricted. A low carbohydrate diet can produce greater weight loss in the first months compared to the low fat diet. The patient's adherence to their diet should be frequently be emphasized. You can see in these pictures you have to include in your dietary. Next one is exercise and physical activity. The aerobic exercise prescription and the recommendation for strength and resistance training must go on hand with reduced food intake, and the progression of the activity should be gradual, scientifically based and tailored individually to each person. It is important that physiotherapist finds the most appropriate activity for the individual so that they will not only enjoy the activity but also have a greater chance of staying with that. There are numerous types of exercise prescription that the physiotherapist may use in their increasing effort to battle the obesity epidemic. Physical activity, athletes, the 60 minutes of daily moderate to vigorous physical activity to manage obesity. Sedentary activities, like a decrease in time spent in the sedentary activities. What type of sedentary activities? For example, watching television, playing video games and using computers for recreations. So you have to decrease that time. Screen time should be limited to 1 to 2 hours per day. Next one is the cognitive behavioral therapy. It is also known as the CBT in the management of the obesity. And this strategy have a features which distinguish them for, from other form of the psychological treatment. The Herning et al. The 2005 state that the CBT posits that thoughts and the cognitions medicate, mediate to behavior. So there are three fundamental propositions of the CBTR. First is the cognition affect the behavior. Second is cognition's interpretations may be monitored and altered. Behavior change may be produced through the cognitive change, self-regulations, and by incorporating the concept of CBT into their fitness practice, physical therapists can help obese patients to see the connection between their thoughts about exercise and their behavior. It is most important therapy to manage obesity. That is CBT, cognitive behavioral therapy. There are three steps to do CBT. The first step is to evaluate the patients about the benefits of the exercise and the needs to increase the level of physical activity for long term weight control. The next step is to create a pros and the cons to change table, and patients should be asked to evaluate their reasons for and against adopting an active lifestyle, and it is advised to begin by asking the patients to list the cons of changing, considering whether sedentary life provides them with the something positive that they are afraid to lose. Then the patients are asked to evaluate in the detail of pros of changing their lifestyle, and the list of the pros and the cons should be put on a table and discussed in detail, and every reason for change should be reinforced. And the last final step is to help the patients reach the conclusion that adopting an active lifestyle will be a positive opportunity for a new and healthy life and long term weight control. So, these are the steps to do CBT, cognitive behavioral therapy. Next one is psychosocial intervention. So, building the mindset of active lifestyle. Building a mindset of active lifestyle, parental modeling for the health habits, avoidance of overly strict dieting, it is most important, avoidance of overly strict dieting, setting limits of acceptable behaviors, and the last one is avoidance of using food as a reward or the punishment. Next one is the medication. If the person is overweight or the overweight, the pharmacotherapy included in that part. The pharmacotherapy in combination with the lifestyle modification be considered if the formal program of intensive lifestyle modification has failed to limit weight gain or to modify the comorbidities in the obese children. And in the overweight person, the children should not be treated with the pharmacotherapeutic agents unless significant and severe comorbidities persist despite the intensive lifestyle modifications. This is the last option to manage obesity is the surgery. Weight loss from the surgery ranges from 50 to 70% of excess body weight, and in the most cases there are associated improvements in the adiposity, insulin resistance, triglyceride levels, diabetes, obstructive sleep apnea, depressions, and impaired quality of life. And these outcomes are comparable to those reported for adults undergoing the weight loss surgery. And bariatric surgery on weight loss may have a neuroendocrine mechanism. You can see in this picture, before surgery person looks like obese, and after that it look fit or the slim. There are some criteria for doing surgery. So first is the child has attained trainer 4 to 5 pubertal development and the final or the near final adult height. Second one is the child has a BMI greater than 50 kg per meter square or has a BMI above 40 kg per meter square had a significant or the severe comorbidities. Then and then you can do surgery or the surgeon do the surgery. Third is severe obesity and the comorbidities persist despite a formal program of lifestyle modification with or without medications. So these are the criteria the surgeons have to follow. So types of the bariatric surgery, there are lots of or the 5 types of the bariatric surgeries are available. First is the adjustable gastric band. So you can see here. Next one is the vertical sleeve gastrectomy. Tomy means cutting of that gastric. Okay, so it's like a sleeve, vertical sleeve is there. Raux and Y gastric bypass. It looks like Y, that's why, and Y gastric bypass. Next one is the below pancreatic diversion, means pancreas diversion is available. Okay, and the next one is below pancreatic diversion with a duodenal switch. You can see here like this. Contraindication for the surgical procedure. Every patients or the every obese person can't do the surgery, there are some contraindication for the surgical procedure. So first is the medically correctable cause of the obesity. Second is the ongoing substance abuse the problem. Next one is a medical, psychiatric, psychological and the cognitive condition that prevents the adherence to post-operative dietary medications regimens or impairs the decision capacity. Current or the planned pregnancy within 12 to 18 months of the procedure. And the last one is the Prader-Willi syndrome. Thank you so much.